Okay, so chapter 13 is about the respiratory system disorder. Same thing that we did in the cardiovascular system. We're going to be talking about the physiology first, anatomy and physiology a little bit. Again, I'm not going to focus much on this. This is pathophysiology. So I'm going to focus more on the abnormalities, but let's just understand, or at least refresh our information about what's normal so we can understand what's abnormal. But what's abnormal is what we're focusing on more in quizzes and exams and everything else. So generally speaking, the purpose of the respiratory system is when you breathe, you get oxygen from outside, you kick off or you get rid of carbon dioxide, and the respiratory system is upper respiratory part and lower respiratory part. And when we talk about the pathology of that, you'll understand that we actually need to remember this. What's the upper respiratory tract? From what to what? Are you guys familiar with this? What's the separation between those two, or what determine which is which? That diaphragm, that's for everything. What is it?
Like it's your nasal, right?
Yeah.
Larynx. Yeah.
Yeah, until
Your
trachea. So trachea. Until the trachea, this is upper. Under that, starting with the bronchi going down, that would be the lower. So upper respiratory tract. So if I tell you that this person is having upper respiratory tract infection, so obviously that cannot be something like pneumonia, which is in the alveoli all the way down, or bronchiolitis, for example, which is the bronchioles is all the way down. This can be something like laryngitis, okay, tracheitis, and so on. So we have the components of the upper respiratory tract: nasal cavity, as you guys said, the nasopharynx, which is part of the pharynx that's behind the nose. The tonsils, since we're talking about it, just in case if we have tonsillitis, that will be part of the upper as well. So the palatine tonsils, or the palatine tonsils, these are the tonsils in the palate, under the soft palate, and it's lymphoid tissue. So this is the picture showing us starting from the nose all the way. The last part right here is the alveolus, or the alveolar sac. This is the last part, starting from the nose, going all the way down. That's the respiratory system. Upper will include also, so we said nasopharynx, oropharynx, larynx, trachea. This is all upper. Starting from the bronchial tree, going all the way to the alveoli, or the alveolar sac, that will be called lower respiratory tract. So upper respiratory tract infection of anything, starting from the nose until the end of the trachea. Tracheitis is, okay, laryngitis is, and so on. Pharyngitis, upper, and so on. Anything under that is lower. So do you still remember the bronchial tree? So at the end of the trachea, it will divide into two tubes. What are those two? Right and left what? Primary bronchi, and the primary will give you secondary, tertiary, right? And then bronchioles, thermal bronchioles, respiratory bronchioles, alveolar duct, and then the alveoli at the end. Okay, so you have right and left primary, you have the secondary, bronchioles, sometimes you call it tertiary, sometimes they say bronchioles. But after that you have the terminal bronchioles, respiratory bronchioles, ducts, and the alveolar duct is like if you're holding like an apple or something, the part that's holding the apple, this is the alveolar duct, and the apple itself is the alveolus, or the alveolar sac. And this would be the end point, and this is where the exchange occur, and the exchange occur in those two. Actually it's three. The exchange occur in the respiratory bronchioles a little bit, alveolar duct a little bit, and the main thing is the alveoli itself, the sac. This is where the actual exchange of carbon dioxide and oxygen occur. Ventilation is the process of inspiration and expiration. You inhale and you exhale, right? So This is basically the ventilation. And the volumes, let's have an idea about it. The pulmonary the pulmonary volumes, because this is going to be important later on when I say the tidal volume will be less. So you should know what's the tidal volume if you forgot it. Residual volume and so on. What's the tidal volume? Tidal is like the sea waves, like goes up and down, which is exactly like this. You're sitting down and your tidal volume is half in, half out. Half liter in, half liter out, right? The whole day long. Half liter in, half liter out. Unless you're doing something different, you can be more, you can do more, a lot more, but as long as you're sitting down, you're relaxing, it's always half in, half out. Tidal, in, out, in, out. This is tidal volume, and this is where the name came from. Looks like tides, go up and down, up and down. Residual volume is the volume that stay in the lung after maximal respiration, which is like this. This is a tidal volume. Still, there is a space in, right? The remaining part, okay, after maximal expiration. So this will be the residual volume, which is residual, extra. You still have it. Vital capacity is the maximum amount of air that can be moved in the lung in the single forced inspiration expiration. So forced meaning this all that you can actually use all the way up, all the way down, all together. This is called the vital volume. Okay, so residual. Tidal is what goes up and down, and this is usually half. Residual volume is what resides or stay after forced expiration. Inspiratory reserve. This is your reserve if you wanted to do more. Like this, I'm doing half. Can I do more? Liter in, liter out. So you have a reserve that you can use if needed. And this will be your reserve inspiratory and expiratory. Inspiratory is more, it's about 3 liters. So you can take half in, half out, and you can go with all the way until you get it to 3 liters. Out is less. Vital capacity is the maximum amount of air expired following maximal inspiration. It goes exactly like this. This is tidal volume. And then you get like this. Anything in between those two, that's your vital capacity, right? So what's remaining after when I do like the maximal inspiration and then I go it out, I force it all the way to the end. This is the vital capacity. What's remaining under this? There? The residual volume, which is what stayed in there and you cannot force it out. And the total lung capacity will be, if you're adding those together, that will give you the total lung capacity. I'm not sure if I have a picture or not. But anyway, so tidal volume, residual volume, vital capacity, inspiratory and expiratory reserve volume, total lung capacity is everything all together. The way we control the ventilation, of course, if you sleep, if you go to bed and sleep, you still inspirate and expirate, right? The respiration does not stop. So obviously this is something automated in our brain. Which part specifically? The medulla is what set the rhythm. So you are breathing 18 times per minute. Who decided this? The medulla. What if you need to increase it up or down? The pons, which is above the medulla. Do you remember the brainstem? So the pons is above. So if you wanted to modify, the pons will do that for you. So this is what we mean, both of them work together. But is it different function? A little bit. The medulla set the base, the pace. And the pons being above it can modify. So if you wanted to do more, the pons will tell the medulla slow down, speed up, slow down, and so on. What is going to tell the pons in the medulla to change? Why would you speed up or do more respiration or less respiration? You get a feedback from other parts. These parts that bring you the signal, part of them are central and part is peripheral. Central chemoreceptors. Chemo means chemistry, right? These are the receptors that detect the chemistry. Chemistry of what? If we're talking about the central, it will be the chemistry around the medulla itself. So what's the chemistry? What do we mean by chemistry? Oxygen, carbon dioxide, and pH, right? So the sensors of the medulla itself will detect the signal, the chemistry, and according to that chemistry, it's going to set the pace of the respiration. And this will be influenced also by the peripheral chemoreceptors. Where is it located? Carotid bodies. And it can be and carotid body and aortic arch, both of them for the baroreceptors, but for chemo, it's more of carotid bodies. And let me ask you this. If you are not doing good respiration, if you are slowing down or something, or if the room does not have enough oxygen, for example, you're slowing down, you're doing weak respiration, what happened to the carbon dioxide level in the blood? Does it go up or down? Up. Do you agree? Up, yes, it accumulates in your blood, right? What will happen after the carbon dioxide accumulates in the blood?
You're gonna start to breathe more.
Before you breathe more, what happened to the carbon dioxide? Does it stay as is in the blood?
No, you'll increase the flow of blood to the heart to breathe it out.
Yeah, these are all secondaries, but what immediately happened to the carbon dioxide after it accumulates, it is going to react with water to make carbonic acid. And this is acidity. What happened to the pH if you're acidic?
It goes down.
Goes down. Did you get this point? Remember this. An enzyme is called carbonic anhydrase. So anytime you have more carbon dioxide, it's not going to stay as a gas. No, part of it will stay, but the other part will start to dissolve. Okay, in the water part of the blood, making carbonic acid, and that's why if you slow down, you go to the process of acidosis, and we need to understand this. Acidosis. This is how you develop acidosis. And you know what's a soda that we all drink? Coke or Pepsi? Do you know what is it? This is actually carbon dioxide. Same thing that's happening in your blood. They get water, they put the Coke, dissolve it, and in the machine they get carbon dioxide, push it under pressure, it will dissolve in the water and it make carbonic acid. And this is what you actually feel when you drink, if you like Coke or something, or soda in general, when you drink it and you feel that sensation like gas coming out of it, it irritates a little bit. This is nothing but carbon dioxide that's forced under tension to dissolve in the water. Same thing that's happening in your blood. Carbon dioxide goes up, dissolve in the water, and that will make carbonic acid. So we're moving toward acidity. And let me ask you the next question. So let's understand this together. What if you are speeding up? What happened to the carbon dioxide inside your blood? Goes down. You get rid of a lot more than you should, right? So carbon dioxide will go down, right? Less carbon dioxide dissolving in the water, less carbonic acid. What is that condition? Yes, but what do you call it? Acidosis versus alkalosis? It's alkalosis. More acid is acidosis, less acid is alkalosis, right? Did you get this point? So when you hyperventilate, alkalosis. When you hypoventilate, acidosis. Did you get this point? We will build on it later on, so I'm just making sure that you understand it. So peripheral chemoreceptors, your blood goes to the carotid sinus, and the carotid sinus will analyze the blood. We'll say, okay, this is more than normal carbon dioxide and more than normal acidity. pH is going down. At the same time, the oxygen will be going down. The carbon dioxide goes up, oxygen goes down. Okay, and this will increase the acidity. So your carotid sinus will send the signal to the medulla, telling the medulla that carbon dioxide going up, pH is going down, oxygen is going down. Obviously, we need to do more. The medulla will send the signal to your chest. Breathe more, until you correct the condition. The carotid will pick up the new condition, which is normal now, and will tell to the medulla, we're fine. Slow down and go back to normal. Are we following so far? Okay. This chapter is long, so I need to go a little bit faster. If you have a question, just raise your hand, okay? So this is how the control occur. You have central and you have peripheral. Both of them detect the chemistry. What's the chemistry? Oxygen, carbon dioxide, and pH. This is what I was just talking about. Hypercapnia. What's hypercapnia? More CO, increased carbon dioxide level in the blood. What's hypoxemia or hypoxia? Low level of oxygen in the blood. Okay, and it usually goes like this: hypercapnia, hypoxemia, hypocapnia, hyperemia or hyperxemia. Okay, so they always go against each other, because when you increase your respiration, get rid of carbon dioxide, and you get more oxygen, and vice versa. This is called the hypoxic drive. What if you have chronic elevation of carbon dioxide? The medulla, the chemoreceptors will become insensitive. Okay? If you're doing that all the time. Like you live in high altitude. In high altitude, oxygen tension is low, carbon dioxide is high, and you cannot like hyperventilate every single day for your entire life. If you live like up in the mountains or something. So you have to compensate for that. Okay? So you're not going to increase much your respiration until you actually need it. What's hypocapnia? And does that lead to alkalosis or acidosis? Hypocapnia. Alkalosis. Okay. Gas exchange. The gas exchange with oxygen and carbon dioxide. Obviously, oxygen goes in and carbon dioxide goes out, and this is called exchange. So this is the blood coming from which part? See if you're following on that. Where is it coming from? This blue blood. Pulmonary artery or pulmonary vein? Pulmonary vein. What brings the blood from the right ventricle to the lung, which is deoxygenated? Pulmonary artery. Yeah, this is the only exception. I know you see it blue, so you think it's a vein. It's not. It's the opposite in the pulmonary circulation. This is coming actually from the pulmonary arteries, pulmonary arterioles, not oxygenated. It will go, oxygen goes in, carbon dioxide goes out. So oxygen move from the lung, from the alveoli, which is continuous with the outside, going to the blood, and the carbon dioxide will leave. So this part will be oxygenated. Pulmonary venules, veins, that will go back to the left atrium, left ventricle. This is a cross section of the alveolus, and it's showing you the normal cells, squamous cells, and it's showing you the capillaries. Obviously, for each alveolus, there will be a capillary to exchange together. But there is another type of cells that we need to know, which is the surfactant-producing cells. It's called type 2 cells. Are we familiar with the surfactant? The surfactant, what's the function of the surfactant? If you have it in the alveolus,
For lubrication.
to keep the alveoli opened. Okay? It decreases the surface tension of the alveoli and keep it open. If we don't have it, it will collapse. The alveoli will collapse. So there is a layer of surfactant here that's lining the whole alveolus to keep it open, and this is released from the surfactant producing cells if you lack it. Or on the other hand, why if you think about this, why if the child was born like before 7 months, they keep him in the hospital? Why? Huh? The lung is not developed. What do we mean by not developed? These cells are not mature enough. The number is not good enough. Unless 7. And 7 months and after, 7 is enough. Not perfect, but enough. Less than 7, not enough. So if you don't go to the if they don't put the newborn in the incubator and they start to give him some breathing, they use CPAP machines or something similar to that to force him to breathe in and out, he will not breathe because he doesn't have enough surfactant. So his lung is actually collapsed. They have to put something positive pressure to force the air to come in, and then you let it out, in, out. And they give them some medications that you need to remember when we go to this part, but remember it, they give them cortisone or corticoids, glucocorticoids. Why glucocorticoids? They accelerate the process of secreting surfactant. What do you call the kids who don't have enough surfactant? Infant respiratory distress. If you heard about this, we will come to this part anyway. But here's one more cell. This is called the alveolar macrophage. Alveolar macrophage. So we have type 1 epithelial cells. These are just regular epithelial cells, okay, through which the exchange will occur. Type 2, surfactant producing cells. The third type is not epithelial. It's called the alveolar macrophage, and this is your last defense against anything goes in. What protects you when you breathe? Is the air filtered? Is it clean air? Of course not, right? It has dust and everything else. It goes in, you have hair inside, it will trap some mucus inside, it will trap some your turbinates inside will trap some. When it goes down, you have cilia that push it down, but anything that escape all of that and goes all the way until the end, macrophage will eat it, will eat your dust to get rid of it. Diffusion of gases. This is a pulmonary site, and this is the pulmonary artery, the pulmonary vein. So carbon dioxide is more inside than outside, and oxygen is more outside than inside. So via concentration gradient, oxygen will travel in and carbon dioxide will go out. The factors that affect that are the partial pressure gradient. Example, if it is outside, it's 100, and inside is 40. The difference is 60. That's a lot. So that will make it easier. If you go to the high mountains, you can feel some dyspnea. You can feel it's hard to breathe because the oxygen tension is lower, and so on. So the difference is called partial pressure. The thickness of the respiratory membranes, and that will bring us later on to the pathology. If the membrane itself is thin, the exchange will be easy, right? Just crossing one cell layer, thickness like this. But what if it is thicker? It will be harder for anything to go through it, right? To cross it. What can make it like this? Maybe inflammation. It's inflamed, so it's getting thicker, right? Maybe fibrosis. A problem happen and start to lay fibrous tissue. It's become thicker. It will become hard to exchange gases, and so on. And there is something called ventilation perfusion ratio, and this is important. We will see it abnormal later on. Ventilation perfusion ratio means the ratio between ventilation, which is air coming in from outside, having a lot of oxygen and less carbon dioxide, and your blood coming from the other side, carrying less oxygen and more carbon dioxide. At this level, when they come together, which is ventilation, which is the alveolus, perfusion, which is the blood. So air versus blood is a ventilation perfusion ratio. And if you're having a problem with this ratio being disrupted for some reason, example, you don't have good blood vessels that bring the blood carrying a lot of carbon dioxide to get rid of and less oxygen, if that's disrupted for some reason, or what if your part of your lung is bad? The ventilation perfusion ratio will be disrupted, right? Are we following? Okay. Again, if you have a question, just raise your hand. I'll be more than happy to answer it, but I just need to speed up a little bit. Oxygen traveling in the blood and carbon dioxide traveling in the blood. Oxygen, just 1% of it will be dissolved. Most of it is actually attached to the hemoglobin, and part of it will be released from hemoglobin. What will be released? The oxygen will be released from hemoglobin when you need it, and this will depend on the pressure of the PO2. What's the PO2? And what's PCO2? What's P? Huh? P. What P stand for? The first letter of what? Yeah. P means pressure. PO2, the pressure of oxygen in the blood. PCO2, the pressure of carbon dioxide in the blood. P is for pressure. Temperature, pH. These are the factors that will tell the hemoglobin leave oxygen or don't leave it. So are we following? The vast majority of the oxygen is not dissolving. It's actually carried on the hemoglobin. When you need it, hemoglobin will let it go, will give it to you. Depending on what? Depending on these factors. So it can give you a little bit, it can give you more, depending on these factors. Carbon dioxide, on the other hand, which is a waste product, 7%, which is more than oxygen, will be dissolved in the plasma. 20% is with hemoglobin, and the rest is diffusing in the RBCs. This is called the oxyhemoglobin dissociation curve. I'm not going to go into the depth of mathematics or statistics or anything else. Just understand one thing about this. There are things that will let hemoglobin leave oxygen easier or keep it. Don't lose it. Should I release it or not? Okay? When we say shift to the right, means easy to leave oxygen. When we say shift to the left, it means hold on to your oxygen, don't lose it. This is what we have to remember from this. Are we following? Yes?
I just got a question from the slide before. Isn't the binding of oxygen carbon dioxide, isn't it with bicarbonate? It doesn't bicarbonate?
The part in the plasma is the 7%.
So the very insignificant is, or at least with the oxygen.
The carbon dioxide, the oxygen is only 1% dissolved in the plasma. Carbon dioxide is 7%. From this, it will dissolve in the water part of the plasma, making carbonic acid, if that's what you're asking about.
Yeah. I'm just trying to understand it.
Okay, so this is a curve, okay? The curve is like this. This is normal. You see in the middle? It's in the normal. If it goes like this, shift to the right. This is shift to the left. What we have to remember is, I don't want to get into the details. Shifting to the right, meaning let oxygen go. Shifting to the left, hold on to the oxygen. So obviously when it shifts to the right, it means you need more oxygen. You wanted the hemoglobin to let go more oxygen. When it shifts to the left, it means you don't need a lot of oxygen, so your hemoglobin will keep it. Shift to the right, release, shift to the left, hold on to the oxygen. Okay? Now if you're having a problem and you need diagnosis, the first thing that can be used is spirometry. Spirometry is a machine that they will ask you to breathe in, and they will measure the volumes that we talked about. They will see your tidal volume, your vital capacity, the total lung volume, and so on. So they will measure everything, because and that's why I'm stressing on this. We have to understand this. When we go to the diseases, I will assume that you already understand. I will tell you tidal volume goes down, the vital capacity decrease, and so on. Okay, because it will be affected with any pathologic condition. Spirometry. This is a pulmonary function test. This is to test your pulmonary function. Is your lung working fine or not? Basically, volumes and airflow. Are your volumes okay? Is your tidal volume is half, which is normal? What's your vital capacity? Is it 4 liters or not? Or 4,100 or less or more? Okay? This is one thing. The other thing is, are you breathing okay? Or there is an obstruction? So these are the two things that this machine is doing, and it gives a report at the end, and it will lead to the diagnosis. Arterial blood gases is something else. There is a normal value for each gas. The oxygen should be this, the carbon dioxide should be around this number, pH 7.35 to 7.45. So it will give you an idea about, is it normal or is it disrupted? Is it abnormal? If it is abnormal, it means something that leads you to the diagnosis. Oximetry is to measure the oxygen saturation. Exercise tolerance. I will allow you, or I will ask you to exercise, and I will see how long does it take to stop and what stopped you, and so on. This is the spirometry. It might not be in your slides. You can just Google it or something. It's just giving you the idea. You breathe in here, and when you breathe in, this is going to move in and out, and it will give us this picture. Okay? This is, what is this? Tidal volume. And what if you bring it all the way up? What is this? Inspiratory reserve. What if you force it down? Expiratory reserve. What's all of this? Vital capacity. And this is a lung volume. You get it? So this is half in, half out, half in, half out. So I'm going like this. I will show you this in me breathing, okay? Okay, this is the reserve that I can use if needed, okay? And then go down. Okay? And then, okay? And this is what they ask the patients to do. Breathe normal. Give me the maximum breathe in. The maximum breathe out. Go back to normal. This is how it goes. Okay? So tidal volume, reserve, inspiratory reserve. This is your reserve, what you can use if needed. Like if you're exercising, do you only breathe just like this, or you go more, faster and deeper, right? So you use part of this, you can use it all the way to the maximum. Maximum. All of this together, 3 parts. Inspiratory reserve, tidal volume, expiratory reserve, that's the vital capacity. This part, you don't touch it. This is the airways inside. You don't do anything with it. So this part right here, which is the residual volume, this, if added to the vital capacity, that's altogether is called the total lung capacity. Okay? TLC. Are we following so far? Okay. Radiography, give me an X-ray. Let me see your lung, if everything is normal or not. If there is an infection or something, it will show up. Okay, again, some dots or some darkness or lightness or something, so it can tell. Bronchoscopy, if needed only, they can put an endoscope in the bronchus inside, and this is basically to directly visualize, to see inside if there is something wrong. If you are suspecting something, you can take a biopsy. These bronchoscopies, these are really advanced. It's not only that you see, they have other options. So you can push something and a part will go out and you can get a piece of the tissue, which is called the biopsy. You can do it while you're inside. You can see lesion, you can see blood or something. So it's visualizing the inside, plus you can take biopsy if needed. Culture and sensitivity. We talked about this. What's the culture and what's the sensitivity? Culture to what? And sensitivity to what? Culture means? Yes, so you feed it, you give it the nutrients, and this is you culture it. And then you, sensitivity to what? To antibiotics, right. So this is culture and sensitivity. Okay, if somebody's having a respiratory disease or respiratory problem, he can show one of these symptoms and signs as we go. And again, later on, we're not going to talk about this again. I'll just say sneezing, coughing, and or any other of the manifestations or symptoms that's coming. So I will assume that you know already. Okay, cough, sneezing, where it come from? What's the difference between sneezing and cough? We sneeze and cough. What's the difference? Sneezing is something irritated your upper respiratory tract. Coughing is something irritated the lower respiratory tract. So it's different, right? When you sneeze, something only inflaming this part, or something irritant, dust or something that's only in the upper. Coughing is inner. Sputum. Sputum is what we can spit, and it can be of different color and consistencies, and you have to know this and you have to remember it because it makes a huge difference. Each disease will have a characteristic sputum that you have to remember. If you look at the sputum and you see it yellowish green, cloudy and thick, this basically means bacterial infection. That will help you with a diagnosis. Are you coughing? Yes, I'm coughing. Do you produce sputum? Yes. What does it look like? It's green, yellow, thick. Okay, I got it. This is bacteria. It's not enough, but at least it tells you. You can primarily make up your mind just by listening or seeing the description. If it is rusty and dark colored, it's literally rusty is exactly describe it. It's kind of brownish a little bit, like you know the rust, how the rust looks like. The sputum looks actually rusty. If it is rusty or dull color, I didn't say blood, right? Not blood. Dusty, have nothing to do with the blood, just brownish a little bit, dusty. If that's dusty, most likely it's pneumococcal pneumonia. And you need to remember that when we come to it, I will say dusty sputum, you know what we're talking about. Okay? So dusty, rusty, I mean, like rust. Did I say dusty? Rust, looks like rust. So this is pneumococcal pneumonia. How about if a patient is coming and he say, I cough, and I produce large amount of sputum that smells very bad. This is very specific. Bronchiectasis. It means bronchiectasis. This is how important this is. It can actually give you the diagnosis. Okay? I cough, and then I produce big amount of sputum that looks and smells really bad. This is bronchiectasis. Not enough. You have to do other things, but it can suggest at least. So it's purulent sputum, foul smelling or odor. It smells really bad. Normally, the sputum does not smell at all. But if it's smelling bad, it's bronchiectasis. And we will come and describe bronchiectasis. It's basically permanent dilation of the bronchi. The bronchi are dilated and dysfunctional from repeated infection, destroyed. We will come to this. Thick and tenacious mucus. If the mucus is very thick, so the patient will say, I have hard time getting rid of it. It's too thick, too adherent, and it's hard to get rid of it. This will suggest a couple of things. It can be asthma, it can be cystic fibrosis. There are other things to tell us what is it, but this is one of them. Okay, and it's tenacious, it's hard, it's tense to get rid of it. What if the sputum is blood tinged? When I cough, I produce sputum, I look at it, I see some blood. This can tell you one out of the two things. We don't assume this is something bad, but it might be. It can be just from chronic cough, you're coughing until some of your capillaries actually rupture from coughing. So you see a little bit of a blood. It can be. Are you coughing all the time? Yes. This might be the reason. But the bad thing is it might mean tumor or TB, and this is the importance of describing this. If it is bloody, can be something mild, just chronic cough. You're coughing the whole day long until you injured your blood vessels. Or the bad one is tumor versus TB. Tumor or TB. Hemoptysis. What's hemoptysis?
Or coughing from one.
Coughing blood.
Oh, cough.
What's hematemesis?
That one's done.
Yeah, vomiting blood. Hematemesis is vomiting blood. Hemoptysis is coughing blood. It's different. What if you're having a patient having hemoptysis? Meaning you cough and the sputum is frothy and blood tinged. It has a tinge. Most likely it's pulmonary edema. The lung is edematous. The blood leaves the capillaries and goes around, give you edema, so that will give you the hemoptysis. Breathing pattern. This is very important, by the way. Each one of those will give us something in the later part. So let's understand it together. Cosmal respiration. Cosmal respiration means deep, rapid respiration. The respiration is not only rapid, not only deep. You can go like this. This is normal. I can go like. This is deep but slow, right? But I can go like this. This is deep and fast, cosmal respiration. So if it's deep and fast, both of them together, that's called the cosmal respiration. And this is a sign of acidosis. It means acidosis. For some reason you're having acidosis. Or if you're doing strenuous exercise, that's another reason, but this is a natural reason. Yes?
Wouldn't it mean that there is too much oxygen also?
No, it's too low oxygen or too much carbon dioxide that's causing, and the rationale, why are you breathing fast and deep? You're trying to get more oxygen for your body and you're trying to get rid of a lot of carbon dioxide. So it means the opposite. It means you have a lot of carbon dioxide and you have less oxygen. So you have to breathe faster. What's happening when we breathe? When we breathe, we gain oxygen and we get rid of carbon dioxide, right? Anytime we talk about more breathing, meaning you get more oxygen and lose more carbon dioxide. Okay? Does that answer your question?
Yeah. No, well, it's more important to get the carbon dioxide out of you than to get more oxygen into you, or is it like...
Both of them are coupled. They have to happen at the same time. We cannot separate them. When you get carbon dioxide, you automatically get rid of. When you get rid of carbon dioxide, you automatically get oxygen. Which is more important signal, carbon dioxide? If that's the question.
Yeah.
It's more important signal than less oxygen. Less oxygen you can tolerate, but more carbon dioxide, acidosis, that can actually hurt your brain or something. So yes, it's a stronger signal if that's what you mean. Eupnea, EU, before any word means normal, right? Cosmal respiration, fast, deep, which means acidosis or strenuous exercise. Strenuous exercise, this is a natural cause. If you're exercising really hard, that's normal. You have to breathe fast and deep. But what if that's not the case? And this is the pathological one. So this means acidosis. Here are the different types of respiration. I'm not going to go through all of them, but if you look at this, look at the first one up there. Compare it to this. It's the same amplitude, right? But what's different here? Yes, so that means faster. Count those versus those. You will see more. So this is faster. This is called tachypnea. Compared to this. See how many in the same? 1, 2, 3, 4. Count this. 1, 2, 3, 4, 5, 6, 7. So this is bradypnea, right? This is about, I know this is a little bit longer, but count, it will be more. So less, more, tachypnea, bradypnea. Do you see this flat line? Apnea, A, no breathing. Okay? Cosmal is this. If you compare this to this, you see this height is more, deeper. And you see this faster. Count this to this. So it's fast and deep. Okay? This is shallow breathing. same as normal, but it's the depth only that's affected. Okay, so 18 per minute, it's 18 per minute, didn't change, but it's shallow. Okay, this is called the Shanstock, and Shanstock goes like this. You go breathing. Okay, it goes more, less, more, less, more, less. Okay? Okay, so these are the most important ones in these types of respiration. Normal, brady, tachy, apnea, Shanstock, cosmal respiration. Okay. Hyperapnea. What's the difference between hyperapnea and tachypnea? Can you compare those to normal? Hyper versus and tachy versus apnea. The depth in tachy is the same, but it's faster. So tachypnea means just faster. That's it. Hyperapnea, it's not faster. Compare it, it's the same, but it's deeper. Did you get the difference? So hyperapnea, same number, it's not faster, but deeper. Tachypnea, it's faster, but not deeper. If both of them together, that will be the cosmal respiration. Okay, labored respiration or prolonged respiration, expiration, it means obstruction. If you have obstruction, you will go like, you take longer time breathing in and out because there is an obstruction in the way. Wheezing or whistling sound, if you hear wheezing, it means obstruction as well. Stridor, this is more noisy, high-pitched. It means something obstructing the upper way, meaning like somebody, a kid or something, swallowed something that goes to the air, partially obstructing, so that will make more sound. It's not just constriction. So these are the patterns that we just talked about. Rales, bronchi, and absence. This is something when you hear with the stethoscope, sometimes you don't hear any sound. Okay? This means this area does not receive any air. There is a problem with this area, completely closed. Bronchi, this is a harsh sound, deeper harsh sound. Rales, this is like a bubbling sound. You know when you know the bubbles, if you like press it and start to give you that crackle sound? This is called rales. Okay, which means like bubbles in the fluid or something. Okay. Dyspnea, difficult breathing or discomfort while you're breathing. Usually, if you're feeling difficulty breathing, it can be either the carbon dioxide is a lot, it's more, or the oxygen goes down. So something that's make it harder for you to breathe. And the feeling is like you're climbing the stairs. If you're going upstairs, second, third floor, you start to feel difficulty breathing. This is how they feel, even though they are not going upstairs or anything. This is dyspnea at rest. Severe dyspnea, which is even more, which means respiratory distress those people will actually be having more. They will be using their accessory respiratory muscles. Do we know the accessory respiratory muscles? Like the diaphragm, that's normal. The external, it's normal. If you use the rest, sternocleidomastoid, and the rest of the abdominal muscles and all these accessories, it means you're having a hard time breathing and you're forced to use the accessory muscles. Flaring of the nose, because you are breathing too hard, their nose will be flaring in and out. Orthopnea. Ortho means standing. Pnea means breathing. And this condition will means that I can breathe if I'm standing up straight. If you ask me to lay down, I will have difficulty breathing. Did we get it? When I lay down, I will find it hard to breathe. So you wanted to breathe while you're standing up or sitting down? Yes, this is called orthopnea. And orthopnea means pulmonary congestion. So if this person asking him to lay down, he will have a problem. I can't breathe well. I have to stand up. Some people actually, if that's severe enough, they sleep sitting down. To that extent, they sleep on a chair or something. If you ask them to lay down, they will have really difficulty breathing, and this is called orthopnea. Ortho, standing up. Pnea means breathing while I'm straight. Can't lay down. Pulmonary congestion. Paroxysmal nocturnal dyspnea. What does it mean? Paroxysmal means come all of a sudden. Okay? Suddenly appear. Nocturnal means night. Dyspnea means difficulty breathing. So this is difficulty breathing that happen all of a sudden during night time. Are we following? Paroxysmal nocturnal dyspnea. And this means left-sided congestive heart failure. Okay? I was sleeping. I was okay. Half an hour or after 1 hour after I fall asleep, I was started to have, all of a sudden, I have difficulty breathing in the middle of the night. Left-sided heart failure. Okay? Why it's left-sided? Because if the left side of the heart failed, it means the blood that's coming from the lung to the left side will stay in the lung. It doesn't come. So if it stayed in the lung will be congested. And this will make it hard for you to exchange the gases. Okay? So paroxysmal nocturnal dyspnea means left-sided heart failure, congestive. Cyanosis, cyans means purple or blue. So cyanosis, bluish discoloration, which means a lot of unoxygenated blood. I think that was something in your exam, like the cyanotic kids versus or children versus the acyanotic. If there is the blood, if it's going from the right side of the heart to the left side versus left to right, if it's going from right to left, for some reason, that will make the cyanosis. If going from left to right, it's less severe. Pleural pain. This is something happen in the pleura, and the pleura will have some friction. So if you ask this patient, stop breathing, do you feel pain? No. Start to breathe. I feel some pain. Why? Because when you stop breathing, the two layers of the pleura are like this. Okay? There is an infection and problems in the pleura. So if you stop, it will go like this. Once you start to breathe, you make this friction. So he start to feel the pain. And it usually means inflammation or infection of the parietal pleura. Friction rub. This is a rubbing sound. If there is a problem with the pleura, usually the pleura, how many layers do we have? The pleura, how many layers? 2 or 3? 2? Visceral and parietal. It's usually smooth. There is a little bit of fluid in between, and when you breathe, the friction doesn't produce any sound or any pain. It's very smooth. But if you have inflammation and those are going to have friction with each other, that can be painful. And if you hear it to the stethoscope, you feel this crackling sound like this from this friction. So this is called friction rub, rubbing sound. Clubbing of the digits. Clubbing of the digits means the fingers will look like drumstick. You know how the drumsticks look like? So it looks like a clubbing, meaning these parts will be Swelling looks like a drumstick kind of. And this means chronic hypoxia. This is a person who's having a problem with his lungs, and it's been there for some time. He didn't do anything, so these parts of the fingers will receive less oxygen, and it will start to hypertrophy. Looks like a drumstick. Okay. So clapping of the digits or the fingers will mean chronic hypoxemia or chronic hypoxia. You're not getting enough oxygen for quite long time. Hypoxemia versus hypercapnia, I think we talked about this. This is summarizing what we talked about, the therapies. We will come to that individually. Now the infectious diseases. The infectious disease, we're starting the pathology now, if we understand all what we talked about so far. Okay, the infection can be in the upper respiratory tract and in the lower respiratory tract. Upper respiratory tract, as we mentioned before, it's anything starting from the nose, going all the way until the end of the trachea. Starting from the bronchi, you don't call it upper, it's lower now. So anything that happened in the nose, like common cold. Common cold is called rhinitis. Rhin means nose. Rhinitis is inflammation or infection of the nose or the inside of the nose, and this is usually viral. So we know that, right? We know common colds, when it comes, they tell you don't take anything. You can get some decongestant or something, or just relax and it will go away anyway, right? So it's viral. It doesn't need antibiotic or anything. It's viral. There are 200 different causative virus, so you don't treat it. Which type are you going to treat? You don't treat it. It's supportive treatment, symptomatic treatment. I have a little bit of a fever or headache or something. Yes, take something, Tylenol or Advil, but no real. You don't take antiviral for colds. Which one are you going to take for? You do what's important to do: hand washing, respiratory hygiene. Don't come somebody's like sneezing or coughing or you're using somebody else's towel or something like that. So obviously this is all hygiene. Symptomatic treatment. I have some pain, headache. Okay, take Tylenol, take something for symptoms, but it's not a real treatment because it will go away by itself anyway. But the problem is sometimes you start with common cold. I got some common cold and stayed for 3-4 days, and then I started to have fever. I started to cough. I started to produce sputum. What happened? If this is common cold? Of course not. The viral infection in general is usually milder. The bacterial in general is usually harder, more severe. This is the rule of the thumb. Anyway, viral meningitis is worse, or bacterial meningitis? Bacterial meningitis. Viral pneumonia or bacterial pneumonia? Bacteria. So the bacteria is usually more aggressive. The bacterial disease is usually more aggressive. I'm talking in general, okay, generally speaking. So if that to happen, you started just sneezing a little bit, you're having some congestion and you're waiting for it to go, all of a sudden you got fever, cough, so you got secondary bacterial infection. Because while you're having the cold, your immunity is fighting and you're weak already. So it's easy for the bacteria to jump in and cause another infection. This is called secondary, and most of the time it's streptococcus specifically. Remember this. Most of the time, not 100%. Most of the time. Which type? Streptococcus. How to know that this person developed secondary bacterial infection? You see the signs of bacterial infection. Fever, productive cough, and so on. So these are the complications. This is what happened. This is a mucosa. The virus actually starts to erode, okay, through the mucosa, inflame it. So you get congestion, you can breathe well, and it can spread a little bit more, or because it is actually destroying the mucosa, any bacteria that's around can invade this part. So upper respiratory tract infection, sinusitis, it's usually bacterial. So the treatment, anytime you hear bacteria, automatically antibiotics. Viral, most likely symptomatic. If it is bacterial, antibiotics plus symptomatic analgesics. You have some headache, some pain, yes, you get something for it. But to eradicate the sinusitis, antibiotics. Laryngotracheobronchitis. Looks complicated, but it's not. Laryngeo means, what's laryngeo? Larynx, trachea, bronchi. So it's inflammation of all of them. Okay? So it's taken from the larynx to the trachea to the bronchi, all of this. And they call it the crop. Okay? So the crop is laryngotracheopharyngitis. It starts from the larynx, trachea, bronchi. All of this together. Okay, so it's usually viral, and the reason is usually parainfluenza virus or adenovirus. So it's usually viral, infecting all of this area. But the causative is one of those, so you need to remember this. And this is not something huge. It's self-limited, so it's usually goes away by itself. Okay, now comparing laryngotracheobronchitis, which is crop, versus epiglottitis versus bronchiolitis. And do not confuse bronchitis with bronchiolitis. This is the bronchus and this is the bronchiolus, right? Bronchi and bronchioles. So laryngotracheobronchitis, okay? It's usually affect younger people, younger kids. This is less than a year. This is from 3 months to a year. This is older kids, epiglottitis, 3 to 7 years, older kids. Virus, this is Haemophilus influenza. So this is something different. This is bacteria. And bronchiolitis is usually virus. RSV specifically. Okay? Pathology, inflammation of the mucosa in these 3 areas that we talked about. This is epiglottis. We know the epiglottis. What's the epiglottis, right? You know, epiglottis, the part that cover the larynx. Well, if you're eating or something, if it's inflamed, that's bad. Usually the cause is Haemophilus influenza. We need to remember that. The part that's above the glottis is inflamed. The glottis itself is inflamed, obstructing the pathway. And this and the bronchiolitis, both of them start gradual. So the kids will start just a little bit of a fever, okay, coughing a little bit, and then they go more and more and more. Epiglottitis, it occur all of a sudden, start now, 5-6 hours later, you start to see these problems. Laryngotracheobronchitis, which is a crop, it will give you some hoarseness of voice, barking, cough, like the sound of a dog barking. Look, it's kind of sound like it. During inspiration, you see some stridors, but in the epiglottitis, there is a dysphagia that characterizes this. Dysphagia. If you're trying to eat, aren't you going to pass by the epiglottis that's closing the airway, and it's inflamed, severely inflamed. So if you wanted to eat anything, that will be painful. Okay, dysphagia, which is dysphagia, hard swallowing. Okay, fever will be really high versus others, so obviously this is more severe. Tripod position. These kids, if they have epiglottitis, they usually, I showed you the tripod position before, right? So this is what they are going to assume. Versus bronchiolitis, this will be more of a dyspnea and paroxysmal cough, flared nose. So they will have more problem of breathing. Acute versus chronic infection. Acute infection, epiglottitis in this case, 3 to 7 years, and Haemophilus influenza type B. This is all covered in the table. I'm not going to repeat that again. So this is epiglottitis. Treatment of epiglottitis, oxygen and antimicrobial therapy. Why we didn't say that in the other two? Because the other two is more viral. This is this is bacterial, so this one is different. Plus, because of the epiglottis that's swollen and make it hard for them to breathe, you might need to give them some oxygen. So it's different. Now the flu, another thing, which is the influenza. This is another viral infection. There are 3 different types, but the one that we get vaccine for most of the time is type A. This is the most prevalent one. And there are a lot of mutations out there, and that's why the more they get the vaccines for more types A and B, and then you add C, and then you still get influenza. Why? Mutation. Okay? It comes all of a sudden with fever, fatigue, aching pain. Did we say that about common cold? So obviously common cold is a lot milder. So if you got one of those, you should know what you got. Common colds is more of sneezing, congestion, right? It's a lot milder. Flu, fever, body aches, your body hurting you, your muscles, you feel more pain. And the problem of the influenza is, by itself, it's hard. It's harder than the common cold. But the problem is it can go down. It's because the flu is usually in the nose, maybe in the pharynx a little bit. But if it goes down, it can produce viral pneumonia. And this is another problem. And it can be actually complicated by secondary bacterial pneumonia. And it happened a lot. If it happened to you before, you have this fever, but you don't have productive cough. Remember this, productive cough. Productive cough can only come in the lower respiratory tract infection, automatically. So if you have influenza or colds or something, you don't have productive cough. You don't cough and have sputum. That's not true. It comes only if you have something lower than that. So you start to have you are having fever already, okay, and you're sneezing, and your bony aches, your muscle is hurting you, and you need to lay down in bed. Yes, this is all influenza. All of a sudden, the fever is getting higher, and you started to cough productive cough. This is a secondary bacterial infection. Okay? And if somebody died from influenza, it's not from influenza. It's usually the secondary bacterial infection, which is pneumonia. Okay? We hear about that. This person died from influenza. No, he didn't die from influenza. It was secondary infected, and he got pneumonia, and pneumonia can cause actually death, not flu. Flu can cause this if this is a person who's severely debilitated or something like that. But in normal people, extremely hard. Treatment, of course, symptomatic and supportive because it's viral. Unless if it is very severe, sometimes they might give antiviral. Okay? We didn't say that about the cold, right? Common cold, did we say that? You don't get antiviral. But the flu, it's more aggressive, more severe, so you might. If it stayed for a couple of days, you're fine. If it's been a week or something and you're not getting better, you might need to use antiviral. Prevention, of course, hygiene, and vaccine. There is available vaccine for flu. A lot of people take it. Now H1N1 influenza, type A. I think it's very famous. We hear about it, right? Come from pigs, birds. It's actually, as far as I know, it's a mutant. It's not a regular one. It comes from mixed genes from pigs plus birds plus humans. It has something mixed between those three. And usually it can affect anybody actually, but it's more likely to affect children or teenagers. It doesn't mean it does not affect adults. It can, but it's more prevalent. The mortality rate that's happening, we were all scared when we heard about this, right? H1N1. Yeah, the mortality rate is high, not because of the flu itself, it's because of the acute respiratory syndrome that can happen on top of or because of, which is pulmonary edema, pneumonia, and this might need ICU. So it's not the influenza itself, okay? It's the complication that can happen with H1N1, which is the acute respiratory syndrome. Scarlet fever. Scarlet fever is a fever due to infection by this type specifically. Group A, beta hemolytic streptococci, which is called the Streptococcus pyogenes. Okay, do you remember the Streptococcus? How it looks like? Strept. This is one type that's hemolytic. The reason why they cut is just if you wanted to know, it's not very important. But if they add blood to the dish agar, if they add blood, these types will destroy the blood. So that's why they give it this name. It's something related to the lab work. Typical strawberry tongue. The tongue actually looks like strawberry. I will show you the picture. Of course, fever, sore throat because it's an infection of the throat. And usually it's severe enough that they get vomiting and pain. And because this is bacteria, by the way, if you know it's bacteria, it's antibiotic right away. If you know it's virus, most of the time it's supportive or antivirus. You can take it automatically like this. If you look at this picture, this actually looks like a strawberry, right? If you focus on this part of the tongue. So strawberry tongue plus high fever, wheezing, dyspnea, vomiting, shallow respiration, cough. This is all sore throat, fever. This specifically, strawberry tongue. These are all signs and symptoms that suggest scarlet fever, and it's bacterial infection. Bronchiolitis. Bronchiolitis, we talked about this in the table. Bronchiolitis is usually viral. So treatment is more supportive, okay, and symptomatic. We talked about this in the table, so I'm not going to repeat. You can take a look at it in the table. Pneumonia can be, usually they classify pneumonia depending on the causative agent. Is it caused by virus or bacteria or fungus? Fungus is rare, but it can. Okay, it can actually produce pneumonia. So is it viral pneumonia? Is it bacterial pneumonia? Is it fungal pneumonia? This is one type of classification. The other type of classification, distribution. We know the lung, the anatomy of the lung, right lung, left lung, lobes and lobules, right? And bronchi. So it depends on the distribution. Is it taking a whole lobe, the upper right lobe? And usually the lower, by the way, just for your information. Is it the right lower lobe, the left lower, the whole lobe, or two lobes? You call it lobar pneumonia. If it is scattered around the bronchi, you call it bronchogenic pneumonia. We will come to this differentiation. Okay, and the other thing is, which tissue is it affected? Is it affecting? Is it interstitial tissue? Is it the alveolar septa? Is it the alveoli? And where is it coming from? What's nosocomial means? Hospital acquired, yes. So it can be nosocomial or community acquired. Is it coming from the community? Somebody infected somebody else? Anywhere? Or is it coming from the hospital? Nosocomia versus community. This is a table summarizing the different types of pneumonia. It can be lobar, and the name gave it away. It's lobes. It can be bronchopneumonia. Still, the name gave it away. It is around the bronchi, and this is where the name came from. So it's pneumonia around the bronchi. Interstitial pneumonia, or the primary atypical pneumonia, PAP. The reason why they call it atypical, because it's not typical. The typical pneumonia is what we're going to talk about, and this will be different. So lobes, scattered, okay? The lobar pneumonia is, if you look at the x-ray, you see one lobe is affected. Looks different than the rest of the lung. Bronchopneumonia scattered, atypical scattered. Reason, Streptococcus pneumoniae, multiple bacteria, can be different reason. And the atypical is either virus, like influenza virus, you had flu, and then it moved it down to give you this type of pneumonia, or mycoplasma. So this is atypical. This is affecting basically the alveoli, the wall of the alveoli. This is affecting more of the bronchi, and it affects also the alveoli. Interstitial pneumonia, it's called interstitial because it affects actually the interstitium around the alveoli. Lobar pneumonia is sudden acute. Bronchopneumonia is insidious, so it goes slowly. Atypical is atypical, so you don't know. It's not typical to anything. Now, the typical of what is typical about pneumonia. High fever, productive cough. High fever and productive cough, this is typical. When you see it, it's pneumonia. Okay? Plus, rusty sputum. If you listen with a stethoscope, you can listen to rales, and then it can be absent altogether. While the bronchopneumonia is usually productive cough with yellow-green sputum and dyspnea. How about the atypical? Again, it's not typical. So it's non-productive cough. See the difference? It's not typical. The typical is productive cough. Whether this, one of the first two is both of them, productive cough. It's different from the type of sputum. This is not productive cough. Okay, if you look at this picture, this is taking the whole lobar. This is taking the bronchi and the adjacent alveoli, so this is bronchopneumonia. And this is atypical. It's taking also the alveoli and part of the lung tissue, the alveoli, but the cause is different. So lobar pneumonia versus bronchopneumonia. Lobar versus bronchopneumonia, we talked about those two. And obviously, what's the treatment for those two? Antibiotic. Both of them are bacterial, antibiotic. But the third one, which is atypical, it's usually virus or mycoplasma. So in both cases, it's not antibiotic. That's called by Legionella pneumophilia. This is another type of organism. And this is usually nosocomial. So most of the time, Legionnaire disease come from in the hospitals, and the organism itself will need a warm, moist environment. That's why it occurs more in the hospitals. It's not the typical pneumonia that we know: high fever, productive cough, chills, and other things, and dyspnea. This is not typical exactly. And if untreated, will cause severe congestion, and it can actually, it's very aggressive, and it can be fatal. Atypical pneumonia, which is, we talked about Mycoplasma pneumoniae. It can be caused by Mycoplasma pneumoniae. This is another bacterial agent that's not typical bacteria. It's not exactly like the typical bacteria. And this is usually transmitted by aerosol, meaning coughing or sneezing or something. So usually cough. It can be caused by mycoplasma, it can be caused by virus, and the severity will be different. It's atypical. Now the SARS, SARS, which is severe acute respiratory syndrome. I think we heard about this. It's a coronavirus. It's called coronavirus that causes it. It's SARS-associated coronavirus, and it's transmitted through respiratory droplets. It usually starts with fever, headache, some diarrhea a little bit, but later on, when it actually affects the lung, this is a severe form. When it starts with this dyspnea, congestion, hypoxia, and the treatment can go all the way to mechanical ventilation, and it can be fatal. That's why it's very aggressive, severe type of respiratory disease. They usually treated with antiviral because it's viral, it's coronavirus specifically, and they give glucocorticoid. When you hear glucocorticoid in general, what comes to your mind?
Inflammation?
Yes, anti-inflammation. It's anti-inflammation. So if you have inflammation, you're having difficulty to breathe. The glucocorticoid will decrease the inflammation, and it will make it easier for you to breathe. The fatality rate is too high when it comes to the source. The next is TB, and the TB is caused by Mycobacterium TB, and this usually is transmitted by oral droplets, and the person has to be actively having the active disease in order to transmit it. If this person having something chronic or is in the prodroma or something, it does not infect. It has to be something actively having an active TB in order to occur, and it's usually more frequent in crowded conditions. So people living in crowded conditions, 5, 10 people, 10, 15 person in a small space or something, or if this person is weak for some reason, immune deficiency, malnutrition, alcoholism, during war, somebody's having a chronic disease or something, HIV and so on, anything that makes the person weak can cause the TB. So the causative organism is the Mycobacterium TB. And the problem with the TB is it's very resistant to a lot of things that will usually kill the organism. Example, drying, disinfectant, you use those, it doesn't kill it, doesn't kill the TB. Sputum, somebody produced sputum and the sputum on the ground or on the floor and it started to dry and you don't even see it, still alive. So it's very resistant to all these measures. It can be killed by ultraviolet, so sun will kill it, heat, alcohol, formaldehyde, and so on. And the thing here is the neutrophilic response is not there. What happened is the cell mediated, they eat it, they phagocytose the TB if you're strong enough, or it can actually flourish and start to invade different parts. So TB usually starts with primary infection. The first time somebody's coughing and he got TB, he go to your lung. This is a primary infection, and what will happen depend on your resistance. If your immune system is strong enough, you're going to eat it. Your macrophages are going to eat it, and it's not going to stay. It will stay alive. It's very resistant. If not, it will invade different parts of the body, and it destroy the lung. So if your cell-mediated immunity is adequate or strong enough, it will go to the lymph nodes and stay there, causing granuloma. And the bacilli of the Mycobacterium TB will be still alive. And it will surround itself with a calcium and the wall, and actually you can see that in the X-ray. You can see like spots like these, white, because the calcium is kind of shiny in the X-ray. So you see spots like these. This will mean this is primary TB because it didn't go anywhere else. It's the macrophage eat it and take it to the lymph nodes. It will stay there, lay some calcium around it. We can see it in the X-ray and still alive. If the individual resistance high, it will stay like this. Okay, if something happened and this person cannot transmit the disease, by the way. So if this is a primary infection, the macrophage take it, go to the lymph nodes, put some wall and calcium and stay there alive, even though it's alive, but it's not infectant. The active is the infectant one. Secondary or the reinfection, this is the one that occur when the immunity goes down. Start to spread like stress or malnutrition or anything else, start to flourish and start to infect the lung and destroy the lung. Treatment is usually multiple factors. They use like 3 medications, triple therapy together. And there is a condition that's called the miliary or extrapulmonary TB, meaning the TB, after working on the lung and destroying the lung, it can leave and go somewhere else, spreading. So it can go to the bone or something like that. This is called miliary or extrapulmonary TB. And usually that happens in little kids, less than 5 years. If this is an active TB, it's usually produce cavitation. We'll see that in the next picture. You produce cavities, destroy part of the lung and have cavities. So when you see the cavities, know that this is the secondary infection or the more aggressive part, and this will produce cough. And they take actually the cough and they look under the microscope or do culture, and they can actually see it from the cavities. This is how it looks like, cavities that contain the organism, and coughing sputum that contain the organism itself. If this is an active infection, they can test for the sputum itself. Chest x-ray will show you, and sputum culture. And if this is the case, they do combination of drugs. They put like 3 drugs, INH, streptomycin, and other medications. They put them together, and it takes from 6 to 12 months, and you are not allowed to stop the treatment. Less than 6 months is not enough. Three different medication, triple therapy for 6 months at least, if not 12 months, and they usually isolate these conditions. And they have to follow up to see what's happening. It's more problem in weak people or homeless or HIV infected, anybody who is weak enough not to resist the TB. Histoplasmosis is the next organism that can infect the respiratory system, and it's fungus. The organism is called Histoplasma capsulatum, and it's usually come from inhalation of dust. This is more in the southern states like Arizona or something like that, where there is a lot of dust, and it lives in the dust, it doesn't die. So if you inhale the dust that gets contaminated, this is how we get our respiratory system infected. At the beginning, it does not have any symptoms, but second will produce granuloma. Okay, what's a granuloma? Oma means like a tumor. This is granular tumor. Tumor doesn't mean actually tumor. It's any collection of cells. So granuloma is collection of cells, looks like and having granules. Together with cough and night sweating and so on. Treatment is antifungal because it's fungal infection. Anthrax is a bacteria that's gram-positive bacilli. By the way, you need to remember these names. Okay, the causative organism. It usually comes by inhalation. It's at the beginning it produces flu-like symptoms, so the patient thinks that he's having just flu, and then it goes to severe acute respiratory distress, and it can go all the way to shock. When it goes to shock, means the toxins started to spread. Treatment is antimicrobial ciprofloxacin, and there is actually a vaccine that's available for anthrax. Obstructive lung disease, cystic fibrosis, that's the first one. And cystic fibrosis is something inherited. It's a genetic problem. And it's located in chromosome number 7. And why are we talking about this? Because if somebody's having cystic fibrosis, his kid during pregnancy might have the same condition, so they can actually analyze the genes. Genetic analysis can tell us there is something that they can actually detect in chromosome number 7 specifically. And this will produce tenacious mucus, which is tense and thick. And it not only go to the lung, it actually goes to the pancreas. And cystic fibrosis, the problem with cystic fibrosis is, basically, every secretion will become thicker. Remember this. Any secretion. So if it becomes thicker, it will block things. Blocking the lung, causing lung problems. Blocking the pancreas, causing pancreatic problem, and so on. And it can actually destroy the wall because of that. Those people can have a lot of infections, like Pseudomonas specifically, and Staphylococcus aureus. It can, I said, the most important thing to remember is cystic fibrosis. What's the problem? Genetic problem. Causing what? Secretion will be thick. Which secretion? Any secretion. Secretion of the lung. Thick, blocking the lung. Secretion in the reproductive system. Thick, blocking the vas deferens, for example. So the sperms cannot go. So this can cause, like in males and females, it can actually obstruct the cervix or the fallopian tube. So that can cause infertility, sweat glands. It will be concentrated. It's the same thing in the pancreas, the digestive system. It will be the secretion will be thick enough, less water. So like meconium ileus. What's the meconium?
First bowel movement of the newborn.
The what?
First bowel movement of the newborn.
Yes, it's like the feces in adults, but this is for kids. So this can actually, because it's too thick, it can block the ileum. This is called meconium ileus. Pancreas, blocking the pancreas. The bile become thicker, blocking the bile. Salivary gland. You can put it anywhere. Just understand the concept. What's the concept? Secretions become thicker, blocking. Blocking what? Anything. You name it. So meconium ileus in kids, salty skin, the skin will be, and this is where you can see people having this white on their skin, the salt. They will have malabsorption because the bile is bad. There's a problem with the bile. There's a problem with the pancreas. So they have this diarrhea, abdominal distension, malabsorption in general, coughing. It depends on where it's happening. So every part that's blocked will be affected by this condition. They can test the genes, genetic testing, sweat test. They can actually take like a swab of your sweat, and they analyze it. You will find the salt, which is sodium chloride. It will be very concentrated, so they can tell. Stool will contain a lot of fat. That's called steatorrhea, and this means you're not digesting your fat. Why? Because you didn't get enough bile. Gas analysis can tell you something. The radiography, everything that's affected. Treatment will depend on the cause, but you're going to replace the missing, whatever missing anyway. Lung cancer. 90% of the cancer is related to smoking. And we have different types of cancer. Bronchogenic, obviously coming from the bronchi. Squamous cell carcinoma, that's coming from the epithelium. Adenocarcinoma and bronchoalveolar cell carcinoma. These are the other types. Usually the bronchogenic carcinoma will be more in the center. So if we have an x-ray and see a tumor more central, it can be bronchogenic and it can be squamous because both of them are in the bronchi. If it is in the periphery, this can be the other types, adenocarcinoma versus bronchoalveolar carcinoma. And this is how bronchogenic carcinoma looks like. What are the secondary effects of if that happened, lung cancer? It depends on what is happening after that complication. It can block the bronchus, for example. It can cause inflammation, bleeding, effusion, hemothorax, pneumothorax. What's pleural effusion, hemothorax, and pneumothorax? Do we know what is this? Where? Yes, but where exactly? Between the two layers, yes. How about pneumothorax? Same thing but air. How about hemothorax? Same thing but blood. Did you get the concept? Accumulation of anything in between the layers. Are we supposed to have something? No. Just a little bit of a fluid just to facilitate the friction. If you put something in between, this is a condition. So remember those. Okay, so these are the effects of cancer. Paraneoplastic syndrome means you have a neoplasia, you have a tumor, and you have something else beside it. Like if these tumors started to produce hormones or to force the body to produce hormone, that will be the paraneoplastic syndrome. Depending on which secretion is produced or which hormone, that will make the difference. Early signs. This is something that too early to tell. Persistent productive cough, a lot of productive cough that does not go away. The radiograph will tell us what it is. Hemoptysis, this person is coughing blood, so you can think, we talked about this before, you can think about tumor, pleura, chest pain, hoarseness of voice, and so on. These are all early factors. Besides, this person will start to lose weight, become anemic, and so on. Or it can be detected by the paraneoplastic syndrome, meaning you have endocrine secretions, hormone that's coming from somewhere that you don't know where it's coming from. ADH, a lot of ADH, where is it coming from? He is having a cancer. So this is called the paraneoplastic. If it starts to metastasize, start to spread, you can see it in the bone pain, motor deficits if we go to the brain, and so on. Of course, I think we're familiar with the diagnostic. CT, you can do CT. This is something called helical CT that goes like in helix to get every single part. MRI, X-ray can help. Bronchoscopy, you can look at the bronchi. You can see the actual cancer. Of course, you will need to get a biopsy to tell you exactly is it cancer or not. And treatment depend on the situation. You can resect part. You can remove the whole lobe. Or you can use chemotherapy or radiotherapy, or you can use a mix of those. Aspiration, if somebody aspirated, meaning something solid or fluid go to the airway, and it can cause obstruction, can cause inflammation, and it is more in the children if somebody is talking while he's eating or eating while he's laying down or something, and this can be complicated by pneumonia. So aspiration pneumonia is one thing that can happen. It can actually lead to respiratory distress syndrome. It can lead to abscess. If that's something settled down in the lung, can cause abscess. And this person will be, of course, coughing, choking. The sound will be different because something solid, like a peanut or something that goes in the airways. So wheezing, he start to wheeze, he start to breathe fast. Tachypnea and tachycardia, nasal flaring, and so on. The treatment of aspiration. Are we familiar with the Heimlich maneuver? When you go like from behind and push this and something goes out. This is in adults, but in children, it's a little bit different. You put him like this, and you start to hit the back in between the two scapulas. This is where you start to push. Okay, so it's different from kids to infants. In infants, you start to eject in the back, blowing in the back in between the two shoulders, and this is usually good enough to kick it out. Obstructive sleep apnea. Obstructive sleep apnea. This is a person who he's sleeping and he stopped breathing, okay? And it goes like this. This is a person who is sleeping and go like, start to breathe, and then usually it goes like this. So stop breathing and then breathe. Stop breathing, breathe. And this is usually, so it's cessation of breathing. He stopped breathing. Obstructive sleep apnea. And this is usually a problem with the pharynx. So the pharynx like collapse, especially if this person is laying on his back. So the gravity will close the pharynx and the larynx, and he cannot breathe until the oxygen saturation, the oxygen goes down, and the brain will wake you up. Breathe. So you go, and then start to relax until it actually closes completely. You don't breathe. And then the oxygen goes down, your brain will wake you up. So those people are poor enough that you can wake up 20, 30, 80 times per night. They don't even feel it. Okay? A lot of people, by the way, they're affecting more than 10% of the population, so it's millions, but they don't know. The chances are, if somebody's snoring, there is a chance that he's having obstructive sleep apnea. So it's an apnea, stop breathing due to obstruction. CPAP machine, if you're familiar with this, the CPAP, it's a machine, they put the mask here, and the air will force the airways to open. There is an alternative that they found in the last 10 years or something, that they can put something, an oral appliance, that push the pharynx to open. Force it to open because it's weak enough, and once you sleep, it will close. So this is something else. Asthma, this is bronchial obstruction. Most important thing. Which part to get obstructed? It's the bronchi. Bronchial obstruction. And those people are usually hypersensitive, or their airways are hypersensitive, hyperresponsive. It can occur in children or adults, and usually those people will have some sort of allergy. If the asthma came from outside, like you smell a perfume, and this will elicit the asthma, or pollens, like you go to the backyard or something and you have it. This is extrinsic. If it's coming from inside, like you have an infection or exercise or stress or medication or something, that's called intrinsic. and it's inflammation and bronchoconstriction. This is the most important thing. So this person will start to cough. He feel tightness of breathing. He wheezes. He breathes rapidly. He produces thick mucosa that's too sticky, tachycardia and tachypnea and hypoxia. It can lead to alkalosis if he started to hyperventilate, and if part is got obstructed, it produce acidosis. It can go to severe respiratory distress if the hypoventilation is bad enough that he's having hypoxemia and respiratory acidosis. If it is too bad, it can go to the respiratory failure, which is a failure of the respiratory system to provide enough oxygen and give enough carbon dioxide. This is how the asthma occur. Status asthmaticus. Status asthmaticus is not the regular asthma. It's asthma that's not treatable. This is a person who got an asthma. You started to give him the spray, the inhaler, didn't work out. Another time, get an injection, didn't work out. So this is persistent and severe. They call it status asthmaticus. So does not respond, and this is a medical emergency because of the hypoxemia. They need treatment. They can get oxygen. They can get injection of glucocorticoids, inhalers, bronchodilators, and so on. If you know that this person is having an asthma, you need to know what he's allergic from and stop him from using this. Like, I'm allergic from cats. Don't have cats. Don't come from close to cats. I'm allergic from food, peanut. Don't eat it. How to know that? They put some. They do the sensitivity test. Did you ever see the allergic test? How they do it in the back or something? They give you almost everything that's known that might cause, until you get and most of the time it's not one thing. It can usually be a couple of things that can actually cause the allergy. Avoid it. Is it something smoking? Away from smoking. Don't sit down beside somebody who's smoking. If it's come from the dust, away from the dust, and so on. So depending on what is causing the allergy, this is for prevention. And they also can work around, improve their ventilation, swimming, walking, and so on. But in the attack itself, they give glucocorticoid. Because the reason why this asthma is occurring is inflammation. Status asthmaticus might need hospitalization. They have their own treatment there, including oxygen that might be needed. But the prophylaxis, if you know that this person is having an asthma that's chronic, comes and goes for a year and year and year, they can use leukotriene receptor antagonist. Leukotriene is a mediator of the allergy and inflammation. So if they stop it with the medication, they can be prophylactic. So you prevent it from it's not for treatment. You prevent it from coming. This is called prophylaxis. Cromolyn sodium, this is another prophylactic. It's called the mast cell stabilizer. The mast cells produce histamine. It stops the mast cells, so no histamine, no allergy. And this is all prophylaxis. It's not a treatment. COPD, chronic obstructive lung disease. This is chronic obstruction of the lung. And it can go to respiratory failure if not treated. Emphysema is the most important variant, and most likely it's emphysema. And this is where the wall of the alveoli and the septa is destroyed. So if this is an alveolus, and this is another alveolus, and here's another alveolus, the wall is destroyed and you have an alveolus like this. Okay? So the alveoli, the wall, the spaces will be larger, and this will make the exchange harder. Usually those people, it's not only because cigarette smoking is one thing, but it can be genetic factors as well, and infection with bacteria. The wall is broken down, the capillaries can be broken down as well, and they can start laying fibrous tissue, which is called fibrosis. The problem with the chronic obstructive lung disease is it's a chronic situation. It's not something that you get a treatment and you're okay. It is aggressive, progressive. So it will go from bad to worse. And if you look at an X-ray, you will see the chest looking like a barrel shape. You know how the barrel looks like? it's rounded like this, right? We're supposed to look like this, right? This is shorter than this. If it is a circle, it means you're expanding. Why did you expand? Because you cut all these walls and septa inside. Because so the lung will become larger, okay, flattened. Larger doesn't mean good, of course. Larger and it's pathologic. It's not doing the job. If it is too advanced, it can go to pneumothorax, hypercapnia, hypoxia. It can cause repeated infection. It can cause actually pulmonary hypertension, and this is important to understand. Pulmonary hypertension. Hypertension that we all know is anything above 140 by 90 or something, right? This is the systemic hypertension. Sometimes there is an hypertension in the pulmonary system itself, in the pulmonary arteries and veins. So this is because of this fibrosis, the tension will increase in the bronchi. Cor pulmonale is another thing that we need to understand. Cor pulmonale is heart failure due to a problem in the lung. So it's not the heart itself is having a problem. The heart was okay, but you're having a chronic problem in the lung that's reflected on the heart, and this is what we call cor pulmonale. Cor pulmonale. So this person was having emphysema. They will have some dyspnea, hyperventilation, anorexia, clubbed finger if that stayed for a long time because of hypoxemia. And the X-ray, which is the chest radiography and pulmonary function, is treatment of COPD. Avoid the respiratory irritants. Immunization to avoid the infection that can provoke the condition. Rehabilitation, they give them some exercise to do to improve their pulmonary function. Breathing techniques, nutrition, vasodilators. And actually, it can go all the way to lung reduction. If this part is bad enough, they can just remove it. This is how the normal person looks like. See how the alveoli looks small and fine. So this is a normal lung with a normal alveoli. This is the emphysema that was all lost. These walls that was here and the septa is all lost, and this is overinflated alveoli. And this is how it can be closed if emphysema occur. Chronic bronchitis is chronic inflammation of the bronchi. And the only time that you can call it chronic bronchitis if it come and stayed for 3 months or longer for 2 years. Less than that, you don't call it chronic bronchitis. You just call it bronchitis. So in order to be chronic, it has to come for 2 years, and in 2 years, and stay for 3 months. And obviously this is bronchitis, so inflammation of the bronchi, mucosa will be inflamed and swollen, fibrosis can occur, oxygen tension goes down, and it can lead to the same thing as emphysema, which is pulmonary hypertension and cor pulmonale. I think we understood what does it mean now. Treatment is usually, if this person is smoking, you need to avoid smoking. Infection should be treated, vaccination, expectorant, bronchodilators, nutrition, low oxygen, and so on. Bronchiectasis is dilation, permanent dilation and damage of the bronchi. Bronchiectasis. And we talked about this, that can give a large amount of sputum that smells bad, full smelling. And the causative can be streptococcus, staphylococcus, pneumococcus, or influenza. And the signs and symptoms would be chronic cough, production of amounts that's full smelling. Treatment is antibiotics, bronchodilators, and treatment of the primary condition.